be moving into, there it is, this meeting is being recorded. And we will also be recording the breakout rooms and posting the entire recording to the HCA website, probably within a day or two of this meeting. It takes a little while to put it all together, but we will put it on the website, so you will be able to watch all the proceedings, including what's happening in the breakout rooms that you might not be sitting in on. All right, I think that is it for our tech moment. I'd like to now turn it over to one of our co-chairs, of Representative Orwell, to offer you a welcome. Let's see.
Unmute.
Oh,
Good afternoon. This is Tina Orwell, State Rep from the 33rd. I want to welcome everyone today to the meeting. I apologize. I don't know if I'm doing a formal introduction beyond a hello. I was out of the office yesterday at a service for families. So, but I do want to say I'm really excited for the work ahead and appreciate everyone being here today.
Thank you so much, Representative Orwell. And now I'm going to ask Amber Leaders with the Governor's Office to offer our land acknowledgement today.
Hi, good afternoon, everyone. I'm calling in today from Olympia, which sits on the traditional territories of the Coast Salish people, specifically the Nisqually and Squaxin Island peoples. Olympia and the South Puget Sound region are covered by the Treaty of Medicine Creek, signed under duress in 1854. The employees of the state of Washington participating today are guided by the Centennial Accord and RCW 43-376, respecting and affirming tribal sovereignty and working with our tribal governments throughout the state in government-to-government partnership. We, and I specifically, respect your right to sovereignty and self-determination and are committed to being better listeners and learners. As we engage in this work today and as it's going forward, it is particularly important that we understand and acknowledge the tribal crisis response system, the Tribal 988 work that was happening even before HB 1477, and how tribal sovereignty relates to the crisis response system. The Tribal 988 subcommittee and our tribal partners will be a critical voice as we move forward in this process.
Thank you so much, Amber. Since it's only our second meeting, I thought it would be good to do another round of introductions of our CRIS committee members. So Liz, would you mind stopping the share for a few moments, and then I'll let you know when it's time to turn it on again. So CRIS committee members, if you could turn on your cameras, I'm going to call on you in the order I'm seeing you on my screen. And I'm just going to ask you to offer a very brief introduction, your name, your preferred pronouns if you like, the organization that you're with, and the group or constituents that you're representing on this CRIS committee. And I'll start with Amber, who's the first person I see on my screen.
Hi, Amber Leaders. My pronouns are she, her. I am a senior policy advisor for Governor Inslee, and I cover behavioral health, aging, and disability.
And Amber is also one of our CRIS committee co-chairs. Puck, I see you next.
Hey folks, my name's Puck. I am in Yakima, Washington. I use they pronouns, and I am, like many many folks of my generation and mental health status, creatively employed. I do disability advocacy in general on a freelance basis, and I talk a lot with LGBTQ, et cetera, communities and communities of color about disparities in services.
Thank you, Puck. Carrie, another co-chair.
Oh, hey everybody, Carrie Waterland with the Division of Behavioral Health and Recovery at the Healthcare Authority. I use she, her pronouns. And I think those were the only things I was supposed to say, right, Jamie? I was listening to the first two and I thought, oh no, I missed what I was supposed to say.
That's right. I think I made a mistake saying co-chair. You were one of our steering committee members, but
right.
not one of our co-chairs. That's right.
Actually, that's the thing I was going to clarify.
Apologies. Yes.
Nope. Thank you for my promotion, but I will gladly give it back to the church.
I understand completely and appreciate your brief service. And then Kathy.
Hi, my name is Kathy Callahan. My pronouns are she and her. I am a community member and a consumer and a parent of lots of consumers of behavioral health, foster parent, step parent, adoptive parent. And I work for a community mental health agency.
Thank you, Kathy. Jessica Shook.
Hi, I'm Jessica Shook. My pronouns are she, her. I am the clinical manager for a crisis team that includes designated crisis responders in Thurston and Mason counties. And I'm also the current president of the Washington DCR Association.
And then Michael Robertson.
Hi, I'm Michael Robertson, Seattle, Washington. I am a certified peer counselor with the agency of Peer Washington. I am a peer services support specialist for King County Drug Diversion Court and King County Superior Court, and that's also a member of National Associated Drug Court Professionals. And I'm also a CIT coordinator certified, and so I'm just glad to be here. Thank you.
Thank you, Michael. And then Joan.
Hi, everyone. My name is Joan Miller. I'm the Senior Policy Analyst with the Washington Council for Behavioral Health, and my pronouns are she, her. Happy to see everyone.
And then Michael Redding.
Hi, everyone. I'm Michael Redding, he, him. I'm the Chief of Crisis Systems and Services for the King County Behavioral Health and Recovery Division. I'm also the administrator for the King ASO, representing the ASOs of Western Washington.
And then another CRIS co-chair. I think I got that one right, Michelle Roberts.
You did. Good afternoon, everybody. My name is Michelle Roberts. I use she, her pronouns. I am with the Prevention and Community Health Division at the Washington State Department of Health, which is where suicide prevention work sits in our agency. And our piece of this work, specifically around 988, is supporting the call centers for that are National Suicide Prevention Line call centers.
Thanks, Michelle. And another CRIS co-chair, Bipasha. Bipasha, you're on mute.
That's got to happen. Bipasha, she, her pronouns, person with lived experience, still live with mental health issues, suicide ideation and attempt, and also a longtime crisis line volunteer. And I'm here to bring all of our lived experiences and ground us in that process. Thank you.
Thank you, Bipasha. And then Justin Johnson.
Good afternoon, everyone. Justin Johnson, I'm the Assistant Director for Spokane County's Community Services, Housing and Community Development Department, which also administers the Behavioral Health Administrative Service Organization. And I'll be representing Eastern Washington Frontier Rural Communities as it pertains to BHASOs. And on a personal note, as a foster care alumni myself, I also bring in that personal lived experience from the voice of children who don't have a voice.
Justin, thank you for sharing that other identity that you bring to the table. It is much appreciated.
Yes.
Heather.
My name is Heather Sanchez, she, her pronouns. I am a social work supervisor for the homeless program here at the American Lake VA in Tacoma, Washington, representing veterans.
Just want to pause for a minute. It looks like we're switching ASL interpreters, and I heard, oh, there we are. So you should see Alana on your screen now. If you're having any trouble seeing Alana and need to access the ASL interpretation, please just send a quick chat to Brittany and she will do her best to help you. Thank you. Let's see, where was I think we were on Kashi.
Hello, Kashi Aurora, she, her pronouns. I'm the Mental and Behavioral Health Program Manager at Seattle Children's, and I'm here representing the Child and Youth Behavioral Health Work Group. Thank you.
And then Dylan.
Hi, Dylan Nishimoto, he, him pronouns. And I work with Asian Counseling and Referral Service. And I primarily work with, I'm with the Children, Youth, and Families Department, and I primarily work with immigrant and refugee families.
Thanks, Dylan. And then Kimberly.
Good afternoon, Kim Hendrickson, she, her pronouns. I work for the city of Poulsbo as the Director of Housing, Health, and Human Services. In that role, I'm a manager of the Poulsbo Fire Cares program, and I'm here on the CRIS representing fire cares programs in the state. I also serve as chair of the state's co-responder outreach alliance. Thank you.
Thanks, Kim. Levi.
Hello, everyone. Levi Van Dyke, he, his pronouns. I'm Deputy Director of Behavioral Health at Volunteers of America, Western Washington, Regional Crisis Line Service Provider, and then a National Suicide Prevention Lifeline Center as well.
Thanks, Levi. Catherine.
Good afternoon, everyone. I'm Catherine Seibel. I use she, her pronouns. I'm the Director of Public Policy and Advocacy at the National Alliance on Mental Illness Washington. And we're a grassroots organization representing people across Washington impacted by mental illness.
Thanks, Catherine. And then Jen Stuber.
Good afternoon, everyone. I'm Jennifer Stuber, professor at the University of Washington, following best practices on crisis care across the country, and personally survivor of suicide loss, and have a community of people who've had that similar experience.
Thank you, Jen, for also sharing your identities with us. That's, again, very appreciated. Adam.
Yeah, good afternoon. Adam Washman. I am the Washington State 911 Coordinator.
Good to see you, Adam. Michelle McDaniel.
Hi, good afternoon, everyone. Michelle McDaniel, CEO of Crisis Connections, also a regional crisis line provider and national suicide prevention lifeline provider.
And then Jane Byer.
Good afternoon, everyone. I'm Jane Byer. I use she, her pronouns, and I am Insurance Commissioner, Kreidler's Health Policy Advisor. Thanks.
Great. And then Darcy.
Hi, Darcy Jaffe, Senior Vice President for Safety and Quality at the Washington State Hospital Association, and I'm representing all 113 hospitals, including the psychiatric hospitals in the state here. Thank you.
And then Linda.
I'm Linda Grant. I use she, her pronouns, and I am the CEO of Evergreen Recovery Centers and the president of the Association of Alcoholism and Addictions Programs.
Wonderful. And then Daria.
Hey folks, Daria Farvar, she, they pronouns. I'm the Public Policy Director at Disability Rights Washington. I also serve as the True Blood class member liaison for that lawsuit.
Great, thank you, Daria. And then Representative Orwell.
Thank you. Tina Orwell, she, her pronouns, state representative from the 33rd Legislative District in South King County, and I'm a social worker and mental health professional.
Great. And then Ron Harding.
Hello, I'm Ron Harding, Chief of Police for the City of Paulsbo. I represent the Washington Association of Sheriffs and Police Chiefs, and he, him pronouns.
Wonderful. And then Jan Tokumoto.
Good afternoon. I'm Jan Tokumoto, and I'm the Chief Operating Officer at Frontier Behavioral Health.
All right, I just want to make sure, please raise your hand if I missed any of our CRIS committee members. Don't see any others on
this is Bob Small.
Bob.
I got on late, so I'm not sure how to raise my hand.
That's okay.
I'm actually having some connectivity problems. I don't have working cameras, maybe residual from the storm yesterday, but I'll introduce myself. So I am a child, adolescent, and adult psychiatrist. I was in clinical practice for many years. I'm currently the Behavioral Health Medical Director at Premier Blue Cross, and I'm representing commercial health plans for the Association of Washington Health Plans.
Thank you, Bob. And then I see I missed Summer Hammond. Summer?
Hi, everybody. Summer Hammonds, Tulalip Tribes. I represent the Native American west side of Washington.
Thanks for being here, Summer. All right. I do want to take a moment also to briefly introduce our staff who will be helping to facilitate today and present. So I'm just going to call on them, and staff, if you could help me out by turning on your cameras for just a moment. We'll start with Betsy Jones.
Good afternoon, everyone. Betsy Jones, Health Management Associates. I'm the managing principal of the Seattle office, and I'm leading the crisis system redesign effort for HMA on behalf of the Behavioral Health Institute at Harborview.
Great, thank you. And then Mark.
Good afternoon. I'm Mark Bodrazic. I use he, him pronouns. I'm also with Health Management Associates. I'm assisting in developing the comprehensive assessment report and will be a presenter today on the themes that we'll be going over shortly. Nice to be here.
And then Michael.
Hello, everyone. My name is Michael Anderson Nathy. I use he, him, his pronouns. I'm an independent consultant that is working with the HMA team to support this process and subject matter expert around health equity. So thank you.
Thanks, Michael. Liz?
Hi, I'm Liz Argent. I'm a senior consultant at the Seattle office, helping support this project overall. It's nice to see you all. She, her pronouns.
Great, thank you. And then Suzanne? Saw you for a second, but I lost you there.
Good afternoon, Suzanne Rabideau, Senior Consultant with Health Management Associates. It's a pleasure to be here working on your system redesign.
Thanks, Suzanne. And then finally, Nicola.
Hi, everyone. Nicola Pinson. I use she, her pronouns. I'm a senior consultant with Health Management Associates and serving as project manager for this work. So great to be here.
Great. Thank you, everyone, for taking that time. We'll probably do that for a couple more meetings until we're in a groove where we feel like we really know each other, and then we can just dive right into discussion at future meetings. Liz, could you do the screen share again? I just want to walk folks through the objectives and agenda, and then we'll move into our work together today. All right, so I do want to alert you to a little bit of a late breaking change in our objectives today. Originally, we had planned to cover two very meaty topics in today's meeting, getting your feedback on the comprehensive assessment and also starting to dive into the discussion of how we will center equity in our work. Frankly, when we did the steering committee meeting last week and heard feedback from CRIS committee members who had observed that meeting and also from our steering committee members, it became very clear that we needed to devote more time to this comprehensive assessment discussion without shortchanging the equity discussion. So we did make the decision to postpone the equity discussion until our next CRIS committee meeting and focus the bulk of our meeting today on the comprehensive assessment. So that is what we're going to do today. That's certainly our most time-sensitive issue. Of course, we're going to continue laying the foundation for our collaboration together and building our relationships with each other. We will spend, as I said, the bulk of the meeting on reviewing the themes and findings from the comprehensive assessment so far and getting your input on systems issues and gaps. Instead of doing a verbal update on subcommittee formation, which is in the home stretch, we're going to provide you with a written update after the meeting so you can be caught up on that. And you should have also received your summaries from the steering committee meeting. So you should be updated on what's going on there as well. We'll confirm action items and next steps, and we'll hear public comment. Liz, could you advance the slide? I'll just give folks the timing here. So we're almost done here with items 1 and 2. We're going to move into our personal stories right after this. And then we'll do a brief ice melter so we can continue to connect with each other and get to know each other better. And then around 1:45, there's going to be a brief presentation on the comprehensive assessment themes. Our CRIS committee members received the slide deck for today ahead of time, so you should have reviewed that in advance. And for our members of the public, it's up on the website. So this is just going to be a brief orientation to that in a few moments to answer your clarifying questions about the key themes. Then we'll take a short break and move right into breakout discussions right after that, facilitated. I'm going to make a slight change to the agenda. It looks like we have 10 people signed up for public comment today. So we won't need the full 20 minutes, which means that we can borrow a little bit of time to like another 5 minutes maybe for our comprehensive assessment discussion. So we will maybe start the public comment closer to like 3:42, and then we will adjourn at 4 o'clock. All right, so that is it for our agenda. I will also go through the public comment process when we get to the end of the meeting. Okay, let's move into our personal stories. Liz, if you could stop the share again. I'm going to turn it over in just a moment to one of our co-chairs to introduce the two people who are going to be offering our personal stories. But first, I just want to say a couple of words. CRIS committee members have asked that these personal stories be a regular part of our agenda to help ground us in our work. And so for future CRIS committee meetings, we would like to open this opportunity to community members who would like to share their personal stories as they relate to the crisis response system. So we will be planning and hosting a meeting before the next CRIS committee meeting for those community members who may want to hear more about the opportunity and how it will work. So look out for an email from us in the next few weeks about when that will happen. We would like to hear from many people in the community, so this would be a good opportunity to get oriented to that. I'm now going to ask co-chair Bhaso Mukherjee to introduce our personal stories. Bhaso, you're on mute. There you go.
I've been thinking a lot about systems versus our personal journeys, and here we are gathered with the intention of building a system for behavioral crisis response. But as we all know, systems can get very impersonal, and they forget that they're serving humans, which is all of us, and we are by no means homogenous. In this process, to keep us grounded in our humanity and our diversity, I'm glad that we will be starting all our meetings with personal experiences. Our first speaker, Jim Vondroff, I had the honor of seeing him as a volunteer at Crisis Connections when he spoke of his experience. He's a champion for the subcommittee on people with lived experience, and his experience is related to substance use disorder. So Jim, please share with us and inspire us some more.
Thank you so much, Bhaso, and thanks so much, Jamie and Betsy and the rest of the team for inviting me to be here with you and share some of my story. As was introduced, I'm Jim Vondroff. I use he, him pronouns. I'd also like to offer my thanks and gratitude to Representative Orwell and Senator Dhingra and others who were instrumental in meaningfully including the voice of lived experience in this important work. So just quickly by way of background, I'm currently the Behavioral Health Senior Advisor for Policy and Advocacy for the Department of Psychiatry at UW Medicine. I'm also the former director of the King County Behavioral Health and Recovery Division. But I'll tell you that of all the titles and roles that I've held in my professional career, I most identify as an individual in long-term recovery, and that's who I'm speaking from today. When I was 17, I made my first attempt to end my life by suicide. It was an incredibly difficult time for myself and my entire family, as you can imagine. My parents had recently divorced and we moved from California to Washington State, and I was struggling with a lot of things. I was struggling with depression and I was struggling with anxiety and, departing a community that I had lived in for, 16, 17 years to move to Washington State. And I was abusing substances to help me cope as I tried to hide the fact that ultimately a lot of this was about the fact that I was a gay kid trying to come to terms with that in Grays Harbor County of all places. So ultimately, I ended up making multiple serious attempts to end the pain and suffering that I was going through in my life. Involuntary psychiatric hospitalization followed, as did multiple emergency department admissions from Aberdeen to Olympia, Puyallup, Seattle, are some of the ones that I can remember. Eventually, I was able to heal from this trauma, the trauma of growing up in an abusive alcoholic household, come to terms and actually celebrate the fact that I'm a gay man and begin what's become a lifelong process of recovery. Sadly, it's only been in the last 8 years that I've begun to talk about and share my recovery story. I started hearing a lot of courageous people share their stories, and I was inspired to speak out. For nearly 30 years, I kept this a secret and I kept it hidden and locked inside myself because I was afraid of what other people would think of me. And I can tell you, it is beyond liberating. This last 8 years have been beyond liberating to be able to stand before you and other groups of people and share that, I eventually became the director of the very organization that involuntarily committed me so many years ago. that I eventually went to work for UW Medicine at Harborview Medical Center, where I helped launch the Behavioral Health Institute and where I was also once a patient on their inpatient psychiatric unit. It's been an amazing journey, and I'm eternally grateful. I remember one time I heard my mom over telling one of my siblings during a time that I was so broken. I was really quite broken during this time, and I overheard her whisper tearfully to one of my siblings, "I think we're going to lose him." And, again, it's liberating to stand before you today as a living example of what a good crisis system does. It offers help and support, and it saves lives. The challenge is that not all the stories of people touching the crisis system have the same positive outcome that I experienced and that my family experienced. And while I'm grateful to share just a tiny bit of really a very complicated, long story in 5 minutes, I also want to remind you that given the right set of circumstances and with the right support, those of us living with behavioral health conditions have the immense capacity to get well and contribute meaningfully in our community. But there are also many stories of promising lives lost and heartbreaking family tragedies and lives that are forever changed. And I encourage the CRIS committee to invite individuals to speak to you about their tragic experiences as well, so that as we embark on this, what I consider a once in a generational opportunity to enhance the crisis system, that we do so with the intention of eliminating unnecessarily additional trauma or losses. I want to share with you something that I experienced recently. I recently led a focus group with a group of individuals with lived experience, which was amazing. I love meeting with people with lived experience who have so much to offer and so much to have for us to learn from. One of the most heartbreaking moments was when I asked the group, what would the crisis system look like if it were successfully redesigned? And while there were multiple responses, there was a theme by both individuals who identified themselves as patients and family members that went something along the lines of, success would mean we left the experience less traumatized than when we entered. I mean, think about that. While not universal experience for everybody, many are entering the system in crisis and leaving more traumatized than when they arrived. I'd like to say, I like to say, and it's true, that we're all just a life event away from needing crisis services ourselves. I mean, just last week, I had somebody call me from Olympia saying, I've got a family member who died by suicide. Can you help us? So this family all of a sudden found themselves in crisis. So we're all just a life event away from needing these supports. And we have a once in a generational opportunity to create a system that supports those in crisis and family members and law enforcement and clinicians and first responders. I could go on and on of who's going to benefit from this system redesign. And I'm so impressed when we just did the introductions, I was reminded of this incredible group that's come together. And I look forward to be a part of this important work with you. So thank you very much for letting me be a part of sharing my story today.
Thank you, Jim. I was inspired when I heard your story many years back. I still am. And I feel like as I've worked so many years in this field, there is an experience that people who ask for services have, which is they feel like the people who are providing services don't know what's going on. And from my experience, people who come to the field to work in mental health, behavioral health, often come with personal stories. And I think we need to bridge that gap and let everybody know that, like Jim said, I could be a moment away from a crisis or a step away from a crisis. So I echo everything Jim said. And I'm also happy to introduce our next speaker, which is Kathy Callahan. I just met her a couple weeks back as a CRIS committee member with lived experience, and she will tell us the story of her experience as a mother to a suicidal child, and to honor the different ways in which we prefer to be in the world and share ourselves, Kathy will be sharing her story with her camera off.
Thank you. Can you hear me? Okay. Back in the 90s, our oldest girl was 12 years old when she first went to Fairfax Hospital. And at 12 years old, unbeknownst to her dad and I, she had over 100 self-inflicted cuts and burns on her little body. And I remember them telling us that, and we both broke down crying. And that was the beginning of 16 placements in 3 different states over a period of 6 years. She made 9 suicide attempts during that time. She used drugs and alcohol excessively. One doctor described it as suicidally. What she said since then was that she was trying to kill the pain or kill herself, whichever happened first. At 14, the at-risk youth petition came to be, and we thought that it offered us some leverage, some way to help force her to get help, because she had run away and was using drugs and living on the streets. And when I went to file the petition, when I went to the DCFS office for the assessment, the man there, they knew my daughter from the receiving center, and she would go there and get bus tokens and condoms and coffee and then leave again. And they told me that the next time I saw her, she would be in a body bag and that I should go home and learn how to accept that. And I was not a nice lady that day. And I said, no, I wasn't going to do that. That I would go file this petition without their help. And they could tell the judge why they didn't do their job or they didn't help me. And they did in the end. Coming out of that office, there was an advertisement for a CAST, a children's cross-agency systems training. And I tore off the piece of paper that had the phone number on it. And I went home and I went out and I educated myself on what was out there as far as crisis. And in 1996, I got to tell you, there wasn't much. The night that I believe they were called the Flying Squad at the time was the nickname for the mobile crisis unit. And they came to our house and she had slit her wrists. Not deeply, but she slit her wrists. And they said to her, we're going to ask you a question now. And before we ask you, we want you to know that if you answer yes, it's a yes or no question. If you answer yes, we are going to call the police and call an ambulance and take you to a hospital against your will and lock you up. And then they asked her if she had genuinely meant to hurt herself or take her own life when she cut her wrists. And she said, no. Wonder why. And they left. Then they left. They told me that if she tried to harm herself again, call 911. Well, I don't understand how that was supposed to help me. My first husband, God rest him, had been a police officer, and I didn't see why calling the cops on a 14-year-old at that point girl who is so unhappy that they're harming themselves. I want her arrested because she's sick. I don't think so. In 2005 was when I finally saw a huge change in our system of crisis response for children and parents. And that was when the YMCA CORS program, Children's Crisis Outreach Response Service, came into being. And they didn't just send a mental health specialist out, they sent a family partner to talk to mom or dad or grandma or caregiver, whoever, and offered them systems and offered them services and didn't try to pound around family into the square hole of what was available. They were flexible. They called back. Within 48 hours, they came back and visited. They stuck kind of stuck by everybody for a couple of weeks. Whereas we never heard from the flying squad ever again. They never called to see if my child lived or died. So I think, and that's just one occasion, I think that I want to be a part of a transformation to the way that we respond to crisis, and to understand that when it is a minor child who has made an attempt in their home, or they're hospitalized with a parent there because they've made an attempt, that we have to speak to the family too. We have to honor their role as the parent or the guardian of this young person. And remember that everybody hurts in a suicide attempt. Thank you very much for listening.
Thank you, Kathy, for sharing that story. It's the first time I've heard a little bit of your story. And as I have heard thousands of stories on the crisis line, my heart is always so deeply moved when people share their stories, because at the end of the day, this system is supposed to work for all of us and make all of us feel that we are seen and we will be supported by our community. So thank you, Jim and Kathy, for sharing. And I'm really looking forward to hearing more stories as the meetings progress. And I hope that we will constantly ground ourselves in the reality of what people live as we build this system, and never forget that we are here to serve human beings. Thanks.
Thank you, Jim and Kathy and Bipasha, for sharing your stories, for your generosity and bravery, and sharing your stories with us. I was watching the CRIS community faces as you shared your stories, and it's a very, very good way to ground us and start us in our work together. So thank you for that. And also for taking another step toward bringing into the light stories for people and making people feel safe telling them. I am looking at our time. I do want to preserve your time to talk about the comprehensive assessment. So I'm going to make the call that we're not going to do the ice melter today. Ideally, it would have been nice to have this time to connect with each other, but I am hopeful that you will still have that opportunity to really connect with each other in the breakout rooms when you are discussing the comprehensive assessment. And so I do want to make sure that we have a lot of that time together. So we will skip the ice melter and we will move into the presentation from Mark on the themes. Before we move into those key themes, I do want to clarify how this is going to work. So, and I also want to make a correction. I had misstated earlier that the slide deck for today, the presentation, had been posted to the website. It had been shared with the CRIS committee, but we will also post it to the website after the meeting so that members of the public can review the key themes in more depth. Today, we are going to be focusing our discussion on getting feedback from you on the key themes and how close we got, where we might be missing some things, and how you've experienced at CRIS committee out in the field and in real life. So Mark is going to offer a brief presentation to orient you to the themes. I know you've already reviewed the document, so this is just going to be a higher level overview. And we'll have an opportunity to ask clarifying questions, but I'm going to ask that if you have questions or comments about the methodology, we're not going to have time to dive into the methodology today. Please do send those questions to the HCA email address. I'll post it again in the chat, and we will compile the FAQs and also take that input into account as we're thinking about the next steps for this comprehensive assessment. Today, I'm going to ask you to focus on the key themes. So what's going to happen is Mark is going to walk through the key themes and give you that high-level overview. Every third theme, please hold your questions, and we will pause after the third theme and take any clarifying questions from CRIS committee members only. Members of the public, I'm sure you will also have questions, and I will ask that you submit those to the HCA email address, which I will put in the chat. So again, hold your questions, CRIS committee members, and then I will pause. Mark and I will pause after each third theme, and I'll facilitate some Q&A. So Mark, why don't you take it away?
Thank you, Jamie. And I just wanted to confirm on my screen anyway, it looks like everything's moved a little off the screen. So is others seeing that as well, or no, I can make an adjustment on my end?
I'm seeing it correctly.
Okay, no problem.
But
There we go.
folks,
Okay.
Okay, great.
Great. Okay, next slide, please. So let's start by saying that, this is the beginning of the journey and certainly not the end as we uncover themes and sub-themes. Thus far, we've had 5 community forums where over 450 community members participated. We've had individual surveys for which the behavioral health ASOs, as well as some providers have responded. We've also done one-on-one interviews with each behavioral health ASO and the managed care organizations. And we've also reviewed some ancillary materials. So for today, we are going to identify the 9 themes, and each one has sub-themes. You can see at the bottom of the slide that in addition to today, CRIS committee members will have the opportunity to provide written feedback until November 30th, and there'll be a follow-up email after today's meeting to remind you and orient you about how you can provide that feedback to Nicola Pinson. Next slide. So here are the slides, the themes. And again, for some reason I'm showing it's moving to the left for me. So let me fix that. We're seeing the other way. There we go. Thank you. The first theme really is centered on the availability of services themselves in the crisis delivery system. The second theme is about the utilization of each of these services. The third theme is around the accountability for who's delivering the services. The fourth theme is about how the financial aspects of the service delivery is paid for, either from state agencies down to BHASOs or to the managed care organizations and ultimately to providers of the services. The fifth theme is around person, family, and community-centered approaches to offering and receiving crisis services. The sixth theme is on collaboration in communities about the delivery of the services. Seventh is the crisis services workforce. Eighth is the use of technology in the provision of the crisis services. And ninth is outcome measures. So we'll go through each one very briefly in turn because we have some sub-themes. So on the next slide, we advance to one more. On the availability of the continuum, what we've uncovered thus far is that the continuum of the services is not consistent across regions of the state. One of the key findings is that the manner in which payments are made for those who may be eligible for the Medicaid program and those who are not could be dictating what services are offered in different regions of the state. Although every behavioral health ASO has a crisis line, there are other crisis lines out there as well, and they vary across the regions. Every region also has mobile crisis teams, but the turnaround time or the availability of those can vary across the state, as well as they're not always easily accessible. Across the continuum, when we think about preventative services, those are often not consistently available across the state. And in particular, crisis respite programs, including peer respite, is also not always funded in every region. Our next theme, I should say this slide is just a brief summary of when we talk about the regions, there are 10 regions that the Healthcare Authority has defined. That's the far left column. And we're showing you for the behavioral health ASOs, which entity is providing the 24/7 mobile crisis line. There are 6 different providers across the 10 regions. There are 41 mobile crisis teams, and you can see the count of those teams by region and the number of crisis stabilization providers, as well as the number of beds. And you can see it's notable that in some regions there are none. On the next theme, we talk about the utilization itself, and we have a little more detailed information to share with you here. But first, let's talk about some of the sub-themes. First, the utilization, like the offerings of services, varies quite a bit across the state. And there does appear to be more of a reliance on involuntary processes and less on more preventative sides. That could be a manifestation of funding, provider availability, or just culture. Those are all things we need to further unpack in the early parts of calendar year 2022. But at the moment, we do see that the volume of crisis calls, and that's controlling for the size of the population in the region, varies, and I have a slide to show you about that, as does the utilization of the mobile crisis teams and involuntary placements. But generally, we notice that there appears to be an over-reliance on inpatient psychiatric beds. And the question really is that because there are less offerings for more preventative or lower diversion offerings in that region? And the single bed certification process continues to be in place as well. On the next slide, I want to orient you to what you're seeing. The top box shows the actual call volume. The two bars, the blue bar is the calendar year 2020 call volume, and the orange is 2021. And we obviously, we're not through 2021 yet. So for the data we have available, we've taken that and extrapolated it for the entire year. So this is just the call volume for the BHASO crisis hotlines. Whenever I say BHASO, I mean the Behavioral Health Administrative Service Organizations, one in each region. And so the top box shows the overall volume. And if you can cursor down, whoever's managing the slide, so we can see the lower portion a little bit better. The call volume down at the per 100,000 residents, that's where we're really looking at the variation by region. And you can see, even though we've annualized the numbers for 2021, in some regions, the call volume is down a little bit from 2020, and in others, it's up. On the left-hand side, you can see our estimate of total crisis line calls for 2021 is higher statewide than 2020 was, 388,000 versus 367,000. And the response time within 30 seconds, which is a key measure, has improved a bit. On the next slide, we look at the mobile crisis teams, and it's displayed the same way. The top box is the absolute number of mobile crisis outreach teams that have been sent out, and we are predicting that there will be fewer in 2021 than in 2020. But you can see on a per 100,000 residents basis, the bottom box, it varies quite a bit across the regions. On the next slide, we look at the designated crisis responder or DCR investigations, displayed in the same way. The top box is the overall number of responsive investigations, and the bottom box shows you on a per 100,000 resident basis in each region. In some regions, it is increasing from 2020 to 2021. In others, it's more steady. But overall, we anticipate or predict that the total investigations is actually increasing in 2021. And on the next slide, this shows you for those designated crisis response investigations, the behavioral health ASOs are asked by HCA to provide the immediate outcome from that investigation, not the long-term outcome, but the immediate outcome. And you can see the blue represents those that received some type of outpatient related service. The yellow is a voluntary inpatient, and the red is detentions, and the gray is something other than those three, a combination of things. The top row is the statewide total volume, and you can see the red, the detentions, is more than half of all of those DCR investigations. But even the red varies by region, but overall, it's quite significant. On the next slide, I think we're ready for We have one more slide here to show you the crisis stabilization beds. And at the bottom, the per 100,000. As you saw in a previous slide, in some regions, there are none, and that's why you see no orange bar for some of the regions. On theme number 3, we looked at the accountability for providing these services. So the state implemented what it calls integrated managed care, which is integrating the physical health, behavioral health, and substance use disorder services together. And when that occurred, the delivery and the responsibility of who is in charge of delivering crisis services has changed. So in 3.1, the sub-theme, you'll see that if the person is on Medicaid, for those services, the behavioral health ASOs at the regional level, what they deliver for what is deemed crisis services actually narrowed. And the Medicaid managed care organizations, or MCOs, took over responsibility for some of these services. But for non-Medicaid clients, the BHASOs continue to deliver the full continuum of crisis services as they did before integrated managed care. In 3.3, in talking to the different behavioral health ASOs and the managed care organizations, that there does seem to be some differences in some of the interpretations because it's a continuum of services, and certain services are received at some time and others later. Where does the line draw between who delivers what? So back to the accountability question, although there are contractual arrangements for the delivery of the services, it does appear in some situations the line is a bit fuzzy on a region by region basis. And another outcome of integrated managed care is that because the behavioral health ASOs no longer are doing the full continuum, they don't have access to real-time data on all of the Medicaid members as they did before. I believe that's the end of theme 3. If someone, yeah, so before we go to theme 4, let's pause here. We're going to have, as Jamie said, a breakout session to discuss these more in depth. But my question to the CRIS committee now, is there anything from a clarification, either terminology or a statement here? And I'll let Jamie facilitate if anyone has their hands up, since I can't see everybody.
So as Mark mentioned, we're looking for questions that will help set you up for that conversation and breakouts. We can save comments and feedback for the breakout discussions, but any questions so far? Use the raise your hand function, CRIS committee. Okay, I see Jen Stuber.
Yes, how do you define a crisis stabilization bed is question 1. And the second one is, how are you differentiating the BHASO calls from the 988 calls? And are those 988 calls wrapped into those numbers you showed earlier, or what happens with those in your report?
So I'll answer the second question first, and that is that our focus and our conversations thus far have been with the behavioral health ASOs, and so our counts are only those crisis lines that they are managing. We are leveraging the information from the 988 preparatory report that is being delivered for information about other crisis lines, and we do intend on joining all that information together. But for now, from an uncovering of the current delivery system for the Medicaid side anyway, we've been focusing on the BHASOs and the MCOs. On the crisis stabilization beds, the way it was described to us is that we're focusing on those facilities for which somebody could be in for, say, a 24 to 72 hour duration period. And so it would be an overnight situation in most cases, but not necessarily a long-term stay.
Mark, I'm just going to jump in here. Carrie sent a direct chat to me saying that crisis bed is defined by DOH licensing, she believes, and maybe Michelle knows. So Michelle Roberts, if you have, I'll call on some other folks here, but if you have an answer to that question, if you don't mind throwing that in a chat to me, I'll make sure to call it out. I see 2 hands up, and then I have a question on the chat as well. So let's go with Joan.
Thanks, Jamie. I also had a question about the bed count. I was wondering if the count of statewide beds was literally physical beds, or is it a current snapshot of what's available? We're hearing that, you know, providers are taking beds offline because they can't staff them. So I wasn't sure if that was a count of physical beds or available capacity. And then I also have a question about the slide on the screen.
Sure. At the moment, the bed count we asked for, so we'd like to acknowledge that the BHASOs as a group have been convening and working through a lot of these conversations even before we were engaged to assist this committee. And one of the efforts they undertook was to inventory their own information. So they shared that with us voluntarily, and we appreciate that. And then after we collected it, we put it back out to them to verify. So the crisis stabilization beds are self-reported by the BHASOs to us about the current beds there. With respect to which ones are available or not on a day-to-day basis, I don't have the answer to that because I suspect that that could vary by region.
Thanks, Mark. And then with respect to this slide about accountability for provision of crisis services, I just want to be clear that crisis providers deliver services regardless of insurance of the individual. So this slide seems more like accountability and confusion about which payer is paying for which services, not which services are delivered, depending on whether or not you're Medicaid or not.
Yeah, I would agree with your assessment. I mean,
okay.
We are going to speak about the frontline providers as well in a moment when we talk about financing, because yes, they're ultimately delivering the services directly to individuals. The accountability, I guess, maybe I'll invite comment on whether it's responsibility for assuring access might be another way we could phrase this, because these entities that we're referencing on this slide are not the ones doing the actual delivery, with a few exceptions.
I'm going to pause for a moment on the raised hands because there's a question in the chat. Can you talk a little more about what the integrated care changed? What in integrated care changed?
I'll let others that maybe have more intimate knowledge about all of the aspects of it. But for this particular project, the integrated managed care, meaning that the managed care organizations that are under contract with the HCA for the Medicaid program ultimately have the responsibility for the provision of physical health, behavioral health, and substance use disorder services. They, as MCOs, can then effectively subcontract the provision of those services to other entities. And they are doing that for some of the crisis-related services to the behavioral health ASOs. And then in other situations, the MCOs contract directly with individual providers. So it gets a bit confusing because the MCO can contract with the BHASO, and then the BHASO in turn can have an agreement with individual providers to deliver services in their region. The same BHASOs can have a contract to deliver services to non-Medicaid individuals in their region as well.
I'm going to just pause for a moment and do a quick time check, because we have a lot of questions and we still have 6 themes to get through in a little less than 20 minutes. So CRIS committee members, it sounds like there's not surprisingly a lot of interest and questions in the topic. I'm going to ask if you could to think about the question you have to ask. If it's something that will help you participate in the feedback discussion today, please by all means ask it. But if you feel like it's something that if it's answered later, that will be satisfying to you, if you could either throw it in the chat or send it to that email address I posted earlier, we will make sure we give you the answers, but to the extent possible, I really want to preserve time for a discussion today. Kim, thanks for your patience.
Thank you, and I hesitate to take any more time, but this strikes me as pretty important with our later conversations. I'm confused about the definition of mobile crisis teams and how mobile crisis teams are used in this document, and I suspect this will come up in our breakout sessions. I work with first responders as part of co-response teams. The way the definition is written for mobile crisis teams, it doesn't seem to include co-response. Also in my county, for example, mobile crisis teams consist of DCRs, so there really is no difference between a DCR and a mobile crisis team, even though they have two different definitions. Just as a quick comment, it would be helpful for me if we could talk about the definition of mobile crisis teams before the breakout, and perhaps the importance of understanding more broadly the things that happen with a mobile crisis team that might not be BHASO funded, because in many communities, those are the kinds of teams that are out there doing the work. Thank you.
Mark, is that one you want to respond to, or is that more about we'll have to give up?
Why don't we wait till before the breakout?
Okay, great. Caitlin.
Yeah, I just want to, hi, Caitlin Stafford. I'm the Managed Care Organization representative here on the CRIS committee. I just wanted to provide a little clarification on our requirements under integrated managed care. MCOs are actually required to subcontract to the BHS ASOs for Medicaid clients for the delivery of crisis response services, but then we have to cover things like on the more of the inpatient side. So if somebody is investigated under an ITA and is subsequently involuntarily committed, we pay for that inpatient stay. We also pay for the voluntary inpatient stay, and we also pay for any sort of crisis stabilization treatment or evaluation and treatment stay. So it's kind of like once they get into the system, the payment sort of shifts back to Medicaid into the MCOs. But then I agree, like on the non-Medicaid side and the delineation of when it shifts over and what the payer is around that, I really agree with Joan. There's a lot of confusion there. It's still kind of messy and hasn't cleared out since we integrated.
Okay, it looks like the other questions we have, I have some in direct messaging that I'm working on getting the answers to, and the other questions we have will wait until later. So Mark, if you could just, when you're going through slides, just grab like the big highlights you want to cover and maybe skip some of the other stuff. We'll leave more time for questions.
And luckily, the last theme was the one that had a lot of detail, and the rest had a little less detail here. But on the financing side, I mean, as you could tell from the conversation thus far, the HCA can make direct payments to the BHASOs if it's a non-Medicaid client. The HCA makes payments to the MCOs, as was just mentioned, for Medicaid clients. The MCOs then make payments to the BHASOs for some services as they are required to, for other services. And then the BHASOs and the MCOs each pay individual providers. So suffice to say, there's lots of different mechanisms around how payments are being made and the financing of the system as a whole. On the next slide, you don't necessarily need to understand what every single box is, other than to say, if you see that there's different ways for different services that payment could be made. So if we just took, for example, the mobile crisis team column, the second column going down the line, if it's a payment from the managed care company to the BHASO, the payment could be made per service to the BHASO. But then in the darker green box in the middle, the BHASO could also be making it per service to a provider, Or it could be more like what's often called the firehouse model, like a 24/7, like the mobile crisis team is ready, willing, and able on a 24/7 basis, and the payment is made for that capacity all the time. But up above, MCOs could also potentially be making a payment under a firehouse model as well. Or oftentimes we learn there's a payment made to the BHASO on an advanced basis, and there's a reconciliation process of sorts. So all we're trying to get at here in this theme is that there are lots of different methods that money is moving around, and it does get quite confusing. And sometimes it just depended upon whether the client is Medicaid eligible or not on how the payment is made. On the next theme, on person, family, and community-centered approaches, there are not really, from what we could tell, systematic standard practices to support persons or families in the current system. So there's always the acknowledgement that each region will have a very different composition and have oftentimes different needs for its community or communities. By the same token, though, to ensure that every individual in the state has at least some standard that they can count on and expect, we are not seeing that throughout the state thus far. And case in point, in the sub-themes, in some regions, there does appear to be more of a reliance on restrictive settings versus less restrictive settings. And oftentimes that's just because the providers are not available to offer the less restrictive settings. In the second sub-theme, the options for individual or family empowerment services, whether it be a drop-in or respite or warm line, are often quite limited in some regions. And then clearly, I don't think it would be a surprise to anyone that we saw significant variations in the continuum of available services and resources, particularly in rural communities. On the next theme, on collaboration. So in talking to behavioral health ASOs and MCOs, we clearly identify and will have in our report examples where collaboration is occurring and working. And so you'll see we have a theme that's the third one down, that there are promising efforts underway that probably should be explored to kind of take to other regions. But what we also observed was that with the integrated managed care implementation, there's less coordination from what we could observe between the HCA and the MCO and the BHASOs on a statewide level to track clients, particularly after a call, say, to a crisis line and a mobile team has been dispatched. And part of the biggest issue appears to be the lack of real-time information to providers who are rendering the services across the continuum about how they could best collaborate. And you'll see that when we get to the technology theme as well. So that's the essence of the next three. So let's pause again. Jamie, I'll let you facilitate CRIS members, committee members.
Yes, I see a question from Representative Orwell.
Yeah, and thank you for your presentation, your work on this. Obviously a complex system. I'm just wondering, for a point of clarity, so there's not confusion, to let folks know the 24/7 crisis lines are not the suicide hotlines, and they're not where 988 calls will be routed. So I just wondered if you can kind of make sure folks realize the difference of the two systems.
Sure, yeah, I mean, we get to, I'll preview just for one moment on the technology side, is that it does seem like some kind of connectedness between these lines is going to be important, particularly as we look at the implementation of 988. They are different lines. The question, I guess, for folks to contemplate and discuss today and in the future is, what is the purpose of every line and where are they needed, and what is the most effective way to integrate this entire system when it comes to the crisis lines and the services that they're providing.
Okay. Michelle.
Well, I think this is an area we're going to have to dig in a lot. I guess I'll just, Jen's asked and Tina's asked, and I know we need some more. We're just getting the Vibrant grant back up, but the 988 calls can only go to National Prevention Suicide Lifelines. And then I think there's going to be handoff because the crisis teams are going to exist elsewhere. And so I just want to be clear, to me, that's where I see the handoff. The initial calls in our state with implementation of 988 and the federal legislation will need to be routed through the National Prevention Suicide Lifelines. And so I think we've given some information on call volume and other things, and then there's going to be more information on the Vibrant findings we've just got. But I think we need to be really clear on that piece, and we can continue to help fill in missing gaps. And I know we have the call centers on this call too. They may want to pipe up here and add some about the set call center hubs, but I do want to just make sure we're really explicit about that in the assessment.
Thanks for that, Michelle. So everyone, please take that to note when you go into your breakouts. That sounds like it's a very important clarification that we have moving forward. I don't see any other hands up, and there's no additional questions in the chat. So Mark, you can move on to the last three themes.
I'll close out. Theme number 7, I think everyone probably lives this every day, and that is that the workforce among behavioral health practitioners is, I think saying it's severely challenged is not overstating what we've observed. And importantly, it appears to be impeding the expansion of services. Back to one of the original themes about the continuum and offering different less restrictive offerings, that is probably a manifestation also of just the lack of available workforce. Peer support specialists are utilized in some regions and less so in others, and potentially underutilized. And then another point of note that probably needs to be unpacked a little bit further for one of the subcommittees in early 2022 is, in addition to just the overall workforce, could there be regulations or other licensure requirements that are also putting up a false barrier to the expansion of services, at least for some of the crisis delivery services? And then lastly, workforce training and standards are varied across the regions. Not to say that there isn't training, but just the kind of a baseline curriculum. Certainly there is for some things, and to get a licensure, there are certain requirements, but kind of the general training is varied. The next theme is on technology. So the behavioral health ASOs call centers are using state-of-the-art call management systems. They can track the calls, they can report on the calls. That's not really the issue that we're getting at here. When we get to what will be the 988 lines, the connectivity between them, as we just mentioned, that is not, well, obviously the 988 lines that are going in are not in yet, but just kind of as a note to be considering as we move forward here. They're not connected electronically, but even within the BHASO responsible 24/7 lines, health technology platforms, and by that we mean whether it be a bed registry or a way to look up for outpatient appointments, those types of more real-time information is not being utilized right now. And then the flow of information itself is fragmented. That's our last sub-theme. It appears actually more so now, ironically, with integrated managed care than before. And then our last theme is on outcomes. So there are some measures that are being tracked right now, but it appears that the level of outcome measurement certainly varies across regions, but even where regions are doing more internal reporting, there's less on kind of the overall effectiveness of the system. So for example, how has diversion to less restrictive care assisted in both the the individual and families' experiences, as well as the provision and availability of the more intensive services where they're needed most, those types of activities. And then the second sub-bullet is that there are national best practices. Washington as a state could probably look to some of these for a more monitoring against some of those best practices. I'm sure that's something that subcommittees will be talking about early next year. And then lastly, other than some of the data you saw today, we're not seeing an easy way for the public, for providers, or for those that have the accountability aspect to see utilization data aggregated at a statewide level to help inform improvement. So thank you for your time today. And I realize I probably took a little more time than I should have, but I think we're ready for the breakouts now.
Let's pause for a moment. Couple more, just a little bit of what showed up on the chat here. So building on Kim's earlier question about some of the non-NCO and ASO related responses, I was doing some direct messaging with Suzanne and Betsy and got some feedback from them that this is definitely something to dive into deeper in the new year, that this is a living assessment. And given the timeframes that we were dealing with putting together this assessment, this is the initial step, but that feedback is well taken. Ron added our law enforcement and navigator responses counted here, and I think that that falls into that same category, although Betsy, please correct me if I have that wrong. I see a hand from Carrie. Go ahead, Carrie.
Thank you. So first, Mark, thank you. This is a big lift and I think a system that is quite complex. So thank you for distilling this down and giving us this presentation. Thank you. And then I say this to provide some context that Healthcare Authority has not had a chance to sit down with this. We're seeing it at the same time everyone else is. And so I think what we know and wanted to just let everyone know is we know that we're going to be working with HMA on this. We know there's probably going to be questions as a result of this presentation today. And so from HCA's point of view, we're just looking really forward to partnering with you on the context and kind of the history. And just thank you for the work that you've done, and looking forward to working more on this. And I know, again, Jamie, thanks for pointing out, this is a living, breathing document that's going to be morphing along the way. So appreciate the work thus far, though. This is big.
Jamie, if I can just respond.
Please, Betsy.
Yes, thank you, Carrie. And just to contextualize all of this, this is our first attempt. We're coming out with what we have heard, and it's really important that we get it right. And so for every single partner, we're going to be, working to ensure that the way we're saying things, the detail that we're providing is accurate. So, Carrie, thank you for flagging that. And, we've got a lot of work to do between here and submission of the report. So really just wanting to say that we know that we don't have everything stated as accurately and as clearly and as effectively as we can state things. So that's the exercise ahead of us. So thanks for raising that issue.
I see a hand from Jen.
I just wanted to ask, I was sort of confused by that Dr. Waterland, that HCA hasn't seen the report. I mean, I'm trying to figure out who monitors the contracts for the BHISOs. It would seem like you all would have a lot of these data, right? Before they actually had to do this survey.
We have been working with HMA on the data. I think my point was that we have not seen this document and this roll-up, and we think that we can provide an awful lot of context and clarity that right now we realize for the sake of the presentation is being presented as bullet points. But we have not seen this document.
The report has not been written yet. So I think these are the high level themes that will then become the detail of the report. So wanting to get the themes right, and then we build from the themes into the report itself.
So when we move into the breakouts, I think that will also be an opportunity to contextualize these initial data analyses and hear from you in particular where there are still gaps and how this plays out in your personal and professional experiences. And Suzanne just direct messaged me to remind me that it's also not just the data reports, but also the feedback from the multiple community forums that were held. So we're just at 2:27 now. I want to give you a short break so you can gather your energy for the breakout discussions. Are there any other clarifying questions before we take a quick break? All right, so let me just orient you to what's going to happen next. So CRIS committee members, when you come back on camera, you're going to be automatically pulled into your breakout rooms. And these are going to be facilitated discussions where, again, we're going to be gathering your feedback on these key themes. And then members of the public, guests, you're going to stay in the main room with me. I'm going to ask you the same questions that are being asked of CRIS committee members in the breakouts, just so we can have that added data point and get your feedback as well. So we'll be having that conversation in the main room for about 40 minutes. And then everyone's going to come back together here, and we're going to facilitate a share out and kind of synthesize everything that was discussed in the breakout rooms. So for now, I'm going to ask everyone take a 5-minute break. I have 2:28 on my computer. If everyone can be back here at, forgive the precision, 2:33 with your cameras on, CRIS committee members, we're going to send you right to those breakout rooms. So see you in 3 minutes, or 5 minutes, excuse me. Thanks, everyone. Okay, everyone. Thanks for being back right on time. Sorry for the speed break. We're going to send you right into your breakout rooms. Facilitators, I want to remind you to hit record as soon as you get into your rooms. And CRIS committee members, if you could help us out and just remind us to record in case we forget, that would be wonderful. So what's going to happen, as I said, is our CRIS committee members are going to move into breakout rooms. You're going to be in there for 40 minutes. And then we're going to come back here and do a share out. Members of the community, guests, members of the public, you're going to stay in the main room with me. We're going to have a similar conversation in here, but you will get to hear everything that happened in the breakout groups and the share out, and of course, watch the recordings later. So I think that's all my instructions. So Brittany, if you're ready, you can send all of our CRIS committee members into their breakouts. All right. Okay, so everyone else who's with us, if you would like, you are invited to turn your cameras on. I would like to have a conversation with you and hear from you about your reactions to those key themes. In particular, I have a few actually focused questions, and you can feel free. This is also that moment where you can feel free to send messages in the chat too, that are more than logistics. If you have feedback on the themes and you would rather contribute them in written form, please feel free to send a chat either to me or to Nicola, who's going to help me kind of monitor the chat as I facilitate our discussion. But what I wanted to throw out there for all of you is what your initial impressions were of the key themes. I mean, what did you take away from hearing that presentation? I know you've had less time to digest it than our CRIS committee members, since this is your first exposure to it. But what are those initial impressions? And feel free to use the raise your hand function. I'll remind you, you can just click that reactions button at the bottom of your screen, and it'll pull up a little window where you can click raise your hand. So use that function if you'd like to speak, or if you'd prefer to send something in the chat, feel free to send a chat to me or Nicola. So what were your initial impressions? Okay, let's start with Joe.
I was trying not to go first, but
well, thank you for being brave and going first.
No, I think so. The key theme. So I'm an ASO administrator, and so the struggles that we've had with the transition integrated managed care, trying to keep the crisis system coordinated and financed, have been significant. And we feel like this report really hits at a high level what some of those challenges are, and the fragmented nature of the funding, the inability to coordinate services to Medicaid members as they move in and out of the crisis system, because we no longer have access to the Medicaid data. So all the issues that we've been raising, I think, get reinforced in this report. There's a few areas of minor inaccuracies, but I think that's to be understood because the system is so complicated and it's so different from region to region that I think it would be hard to capture all those nuances. But for me, the big picture is a pretty accurate description of a very fragmented system that would like to, employ best practices, would like to use more diversion, but diversion resources are limited. I think that point was made that, we don't have the kind of resources for diversion we would like to have. So I think overall, the tenor of the report for me was pretty accurate.
So Joe, yeah, so it sounds like you felt like it fairly well captured what you're seeing as an ASO.
At a high level, yeah.
At a high level, yes. With more specifics as you get in region by region, maybe specific differences. So,
right. Yeah.
All right. I see a chat in here. Okay, we have a member of the public who would like to say hello as the new behavioral navigator for Hoquiam, Aberdeen, and Cosmopolis PDs. I would like to know more about why we are not seeing people who clearly need services let back out of ER to wander the streets in distress. So curious, that's a good prompt if anyone is having any theories about where things are breaking down from getting crisis response service in the ER and then nothing beyond that. And getting back to that original question we asked about your reactions to the key themes, do you think that is that something missing from the key themes that sort of, or do you think that that pretty well captured why that initial response isn't actually getting any follow-up? Or other reactions to the key themes? And I also can put them on the screen. So I know you didn't get a lot of chance to digest, so please let me know if you would like me to put them back on the screen, if there's any in particular that you'd like to see again. Okay, I see Michael.
Yeah, to your point about the follow-up after the ER, I believe one of the challenges that we're facing is that integration with the Medicare side of things and being able to integrate with the behavioral health providers to provide that outpatient care on that urgent need as soon as they're ready to be discharged from the ER. Previously, there were some of the regions that were able to coordinate better with the behavioral health providers to get somebody right into care as soon as they were ready to be discharged. Some of that, I think, has fallen apart there with the integration of managed care. And I think part of what is alluded to in the key themes is that fragmentation, that really being able to tie all that together. And when you look at things like the SAMHSA blueprint on crisis services, it talks about being able to have those connections at the initiation of the crisis all the way through to when they actually are provided those services after the majority of the crisis has been resolved. Those are some of the things I don't think we have those connectivities in order to be able to do at this point.
And so, Michael, it sounds like what you're seeing in the report also is starting to allude to that fragmentation leading to that lack of follow-up and lack of coordinated support. So it sounds like are you feeling satisfied with what you've seen so far in the themes?
To a point, but I think we're there's an elephant in the room, but we're not actually really talking about the elephant.
And what's that?
Well, that we do need to go and have this coordination.
Got it. Okay.
We really do.
Okay, so you would like to see some bigger level, and the solution here is coordination, better coordination, or the need for coordination.
That I believe is a key aspect to it.
Understood. Okay, thank you for that. Stephanie.
Hi, thank you. I'm Stephanie, and I'm with Catholic Community Services Family Behavioral Health. We have mobile crisis teams for youth and families in 3 regions in Washington. And I think, we do see a lot of that variation being in 3 different regions, things happening in different ways, different processes involve different requirements. I think a big gap also is services really do vary based on the insurance type of the individual in crisis. So while we can provide that very brief mobile crisis intervention to any kid, regardless of their insurance type, we also have services for crisis stabilization. That's intensive in-home services, typically for the youth and their family to really be there beyond that 72 hours in the hospital or in their home, but really to provide stabilization services that are key to keeping kids from going to the EDs, going back to hospitals and inpatient. And we only have that funding for kids with Medicaid. Historically, before integration, each BHO region had pools or money set aside from different places that would allow us to serve youth without Medicaid in those stabilization programs. That has largely gone away. So we are really limited in only being able to provide those stabilization services to kids with Medicaid. And I think that's a huge gap and a reason for seeing kids without much between a hospital visit and outpatient services.
And so Stephanie, when you're looking at how those key themes are capturing that, I just want to make sure I'm clear. It sounds like at a high level, it's capturing it and you're adding more detail based on your professional experience. Is that?
Yeah, and it would be helpful for me if you wouldn't mind putting them back on the screen.
Sure, yeah. I'd be happy
ahead of time. Yeah, I think so. I think there was just that question that came up about, why is it that we see people leaving the hospital who are still in distress? And I think sometimes, unfortunately with integration, some of that non-Medicaid funding has gone away in our experience. And so we're really limited in who we are able to serve now in ways that we were not before.
Okay, and forgive me because I always struggle with Zoom, making sure I'm putting the right view on. Are you seeing the full view or just my notes view?
Notes view.
I'm sorry?
The notes view.
Okay, let me see if I can make this work properly. Bear with me a second.
Jamie, it's Nicola. Let me know if you want me to share my screen.
Actually, you know what, Nicola, that would be great. Thank
That way
you.
you can-
That's a really good idea.
Yeah.
I love that. Then we will divide and conquer here. So.
Yeah, and I just quickly, I could see one of the slides, and I think that was represented well, that Medicaid versus non-Medicaid makes a difference in the service continuum. So I think that is a huge area that needs to be addressed.
Stephanie, thank you for that feedback.
Take me a
And
moment.
Nicola, thanks for jumping in with the screen.
Absolutely. It'll just take me one moment.
Okay, while you're doing that, I'm going to call on Kelsey.
Perfect. I think that looking at some of the key themes, and then for me taking into account the question about coming out of the ER, one of the things that I think is missing from some of the slides around detainment and DCRs, deciding whether or not somebody should have outpatient or voluntary inpatient or detainment, it would be important to look at how many of those people who are being referred to outpatient or other services on that graph are actually engaging and utilizing those services. I think one of the things that we really struggle with, I work for a law enforcement agency in a rural county, is that people are not meeting that higher level of care need in terms of involuntary detainment, but they're also not utilizing those outpatient services that they are being referred to. So we see them go through that kind of revolving door. So I think when, kind of looking at the utilization of services, it would be important to look at how many people are being seen in the crisis system that then aren't able to effectively engage in those outpatient services that they're being referred to, whether that's because of barriers to access to services or whether that's because of the nature of their mental illness or chemical dependency concerns. I think that we really miss some of the important information when we kind of leave that category out of, yes, they were referred to services, but are they engaging in those services? And is that part of the reason that we continue to see them cycle through 911 or ERs?
That's a great point, Kelsey. So it sounds like and Nicola, do you mind, I can't remember which slide that was that we were tracking that, but it sounds like not just tracking referrals, but actual utilization and uptake. And you even, I think I heard you mention also, what might be some of the reasons why people aren't actually engaging in those services to which they're being referred.
Yeah.
Is this the slide you were thinking about, Kelsey?
I think maybe one or two more.
Okay.
It's like a blue, yellow, and that one.
That one, yes.
Yes.
There we go. Thank you. Got it. So the blue, the outpatient services are people actually.
Yeah, the blue or the gray, I think a lot of people don't meet detainment criteria, and then we see them continue to cycle through trying to meet detainment criteria for first responders. And I think part of that challenge for us is whether or not those people are engaging in the services that are a lower level of care. And we often see that that is not the case, that they are not participating in those outpatient or lower level of services.
Great, Kelsey, thank you. And I see in the chat that Mark Bollinger would like to make a comment. Mark?
Hi, thank you. This is Mark Bollinger. I've been in working in the system for quite a while, and I provide direct services now. In this, my original comment had to do with the emergency departments, excuse me, and I'm just using Grays Harbor specifically, that if folks do show up at Grays Harbor, and our crisis system works fairly well, for what it can do. But when people are needing, not an inpatient level of care, timely access is what I should say, to outpatient services is a challenge for folks, just because they're in crisis, they're needing something, they want it now. They're not wanting it in 14 days or 10 days or 3 weeks or whatever. They want it, relatively, but hopefully that day or the next day. But what occurs in a lot of cases is the hospital will just do a discharge, say, here, go to some of these places, and there isn't communication. So, and as far as the report goes, I agree at high level, agree with Joe Valentine and a lot of the other comments that were made. But again, the BHAs also don't have workforce, especially in the rural areas. So providing access or actually getting the right service at the right time and the right amount is often a miss. And it's not because the BHAs are not trying to do that. It's they literally can't at this point. Transportation's an issue, limitations. A lot of people want to be seen face-to-face, and a lot of agencies are still having modified face-to-face visits, or they're not, going out into the communities where the folks are. And, they have it takes them all day sometimes to get into, a follow-up appointment. But I think it really has to do with timely access and coordination. And I know in the past, the crisis systems, at least for the Medicaid population, some of the uninsured population did a pretty good job of reaching out to individual agencies to make sure that people were getting in. The mobile crisis teams in particular provided that sort of bridge gap with a couple, calls, maybe a face-to-face or whatever, until the person was engaged in services, or at least got to the front door. As far as remaining engaged, there's a variety of reasons. Sometimes the crisis is resolved and they don't need services anymore. Mm-hmm. But it is a challenging system. It's been more challenging, due to the pandemic. But access and workforce is huge in the rural areas. So that's all I had to say. But again, well, I guess I just want to reiterate this. The emergency departments are busy, and they will just write a discharge plan and send them out. And then law enforcement picks them up again. It's just a cycle in the system. And that's happened in some hospitals for as long as I can remember, over 20 years. So it's not a new problem.
Well, and Mark, I think that is a really good response to the comment that was made earlier by our behavioral navigator regarding people getting discharged and then back out on the street. And they also mentioned that after their first few weeks they were helping to facilitate moving people off the streets into care and find them the next day right back outside in the elements. So and the point that you made, Mark, I've heard echoed many times by CRIS committee members. And so I think this is something people are seeing across the board. Point of clarification, there's a question in here. What does the detentions category mean on the slide that's on the screen? Jail or involuntary treatment? Nicola, would you or any of our other staff who are in the main room, I know our experts who worked on the report and this graph are actually facilitating breakout groups, but if Nicola or someone else on the screen has, someone else from staff can answer that question, please jump in here.
Thanks, Jamie. I'm gonna message Mark about that because I don't have a
Okay.
response or an answer.
Well, let's wait on that. I know Mark's going to be facilitating. Mark's facilitating, so I don't want to distract him since that's. But we can ask that one later. It's a good question. And then I see Michael White.
The dispositions of the events from the designated crisis responders, those detentions would be involuntary treatment detentions.
Okay. Great. So Nicola, actually, would you mind throwing that in there? We have a group text so that the facilitators can talk to each other if questions come up. So since we can't use a chat with each other, so Nicola's going to send that over and make sure that everyone else knows about that one.
And can you repeat that again? I'm sorry, I just missed I heard it, but if you can just repeat it one more time so I get it right.
Certainly. The outcomes of the events from the designated crisis responders that are detentions are involuntary hospitalizations.
Okay, so other initial reactions. Maybe I'll steer the question to what are we missing? So, I'm hearing some satisfaction at a high level with some additional detail that you're offering based on your professional experiences. Anything that you wished you saw in these themes? And if it would be helpful for us to go back, maybe Nicola, can you go back to that slide 3, or not slide 3, the slide that lists all the themes, just so people can remind themselves.
Sure.
And I will call on Susan.
Sorry to scroll. There we go.
Thank you. One of the concerns I have is that a bulk of the population of our state is in King County, and then two of the largest school districts in the state, Seattle and Lake Washington School District, are in King County. Yet it seems that King County is grossly underserving its population. That's one comment. And the second is that I would like you to focus specifically on addressing the needs of children preschool through grade 12, because they are our most vulnerable population. I'm the federal legislative chair for Washington State PTA, and we are very concerned about the mental health of children. And I will talk more about that in our community comments, but those are two observations that I have that I think our membership would support me on. Thank you.
So Susan, just to clarify, it sounds like you feel like when you're thinking about what's missing here, you'd really like to see something that's specifically centered around children and the younger children in particular.
Children and youth.
Yeah.
Preschool through K. And I just like to make sure that the committee members understand that, preschool children have crises too. And,
yes.
And we need services in the schools to help children feel safe so they can navigate and request those services. Children are vulnerable because they're in family homes, and it may not be a safe environment, and that may be the reason why they are experiencing mental health crises. And so the school becomes the safety net, and they need to feel like they're trusted adults who are trained to help them seek the services that they need.
Thanks, Susan. And then Joe.
Right, and just the point that Susan is making, the crisis services for children are very thin across the state. In the North Sound, we separately track calls and dispatches to youth under 17, and it's a very different profile. But the question about what's missing, I think maybe it was beyond the scope of this assessment, but as BHOs, we thought of the crisis system as the crisis line, mobile crisis outreach teams, crisis stabilization facilities, triage facilities, withdrawal management facilities, evaluation and treatment facilities, peer outreach teams, the PACT program and the WISE programs, which provide crisis services to their members. So it's a much broader array of things. And when we're looking at the 988 line and what will make it work, we've got to look at that whole ecosystem of crisis services and not just mobile crisis outreach teams, because without the rest of that system, it's going to be really hard for those two particular modalities to keep up.
And Joe, that is also something I've heard several times from CRIS committee members, so I appreciate you echoing that. Melissa.
Hello. I just wanted to speak to communication being something that we are missing. I am the navigator working with law enforcement and fire rescue. And my whole position was because it's even between first responders, communication was lacking. But where I am, the hospital can't speak to law enforcement, can't speak to the fire department, can't speak to the DCRs, can't speak to WISE and PACT services, and they can't communicate back. We can call Volunteers of America to request a DCR, but we can't speak directly to them unless we have a special grant in order to employ a DCR. No one can talk to anyone else, and I think it's all under kind of the HIPAA flag, but and worries about that. But as I saw a lot of language around coordination and collaboration between systems, but no one can speak to anyone else. And I know that that's a problem in many, many places. So I just wanted to bring up communication specifically as a huge barrier to folks making it through systems that can't talk to each other.
I appreciate that. So when I'm looking at for example, at theme number 6, sounds like you're saying, in addition to some of the other things they articulated, it's those barriers to communicating and the hoops that you will have to jump to share information, some of which you can't share at all. That's very
correct.
helpful. Yeah, thank you, Melissa.
I should add in at least our county, our community health agency has a special release of information compared to the hospital, compared to first responders. There are several releases that have to be signed as someone goes through the system. And if any of those are missed, that just creates kind of a black box for that agency that didn't get their special form signed.
Well, and I imagine that creates delays in situations where a quick follow-up would be really important.
As first responders, we are in the field in an emergency, and signing forms is not always our first priority.
Of course. Thank you, Melissa. Other thoughts, whether it's raising your hand or throwing it in the chat about what you feel like might be missing. And please let us know if it would be helpful for Nicola to put any of the slides on the screen for you. So I'm also hearing from folks, you've been really generous in providing your own thoughts on how these themes relate to your professional and personal experiences. Another prompt question I had for you is, which, if any of these themes, do you relate to in particular based on your own personal and or professional experience? And we've heard a lot about the fragmentation and collaboration. So other themes that stand out for you, and I see Patty. Oh, Patty, you're muted. There you go.
Okay, thank you. I'm not sure it's time for people, who are in the community to talk. Should I save my comment for later?
No, please, if you have feedback on these key themes.
Okay.
Yeah,
well, I just wondered where programs like PACT and ACT and AOT, which supposedly our state has, but I haven't seen it yet. And we have a son who's been ill for 7 years living with us. So we really, we've noticed that there are, I think there's maybe 3 in Seattle, there's maybe 3 PACT programs, or maybe 1 in Tacoma, or an AOT program down there that we've heard about. But where does that fit in, for care for people after they've been hospitalized, after they've been stabilized, and then they need help with follow-up and getting to their meetings with doctors and therapists, and getting their meds and different things like that. You know, we're older parents, we're in our early 70s, and we're probably can't do this much longer. You know, we're doing the best we can, but sometimes an objective third party can get someone to do something better than the family can. So I'm wondering where those services would fit into any of this.
Okay, that's a great question. So in looking at what's missing in these things, it's that that follow-up and support and maintenance that might happen after someone has stabilized to help them remain stable and prevent another crisis. That's a great point. Make a note of that. When we do this share out, I'm hoping to have an opportunity after we hear from the facilitators in the breakout rooms, hoping to have an opportunity to summarize what we talked about in here too. If we don't get to it, I will make sure that we add what we talked about to the summary that goes out so that our CRIS committee members can see what you all had to say today. Other feedback from folks in this room about what is missing here, or which of any of these things particularly stand out to you as relevant based on your own professional or personal experiences. And Patty and Preston, thank you so much for sharing your personal experience with us. That's really meaningful. Michael.
Some of the data that was provided, there are what appear to be some outliers. And while those are just key themes and some of the sub-themes, is the report going to go into some more context as to what those outliers are? For example, like, you know, Greater Columbia, almost all of them are detentions or other for the DCR events. That seems a little odd to me. But just, you know, kind of additional, you know, numbers and graphs are pretty, pictures and all that are nice, and you can get some information from that, but sometimes some of that additional context really provides more meaning to it as well.
So Nicola, can you put up that slide we had up before? It was the one with the blue, yellow, and red and gray. It was the horizontal bar chart.
Sure.
Okay, so Michael, you're referring to that. Yes, that does stand out there. Greater Columbia, it's almost entirely detentions and other compared to the others. And it looks like Jim might have some help here. And Michael, your question was, are we just going to throw these graphs in here? Or is there going to be some contextualizing in the report to help people understand, particularly some of these outliers? Correct. So Jim.
Hey, Jamie. Hey, thanks. I don't really have a answer to that question, but I had a similar question about this particular slide because that stood out to me. It also stood out to me that Thurston Mason is the only place that doesn't have other, and so that seems super interesting. I'm very curious about what all these others are. And then I also was wondering about, and seems to be missing, my own hypothesis is that we have an over-reliance on mental health ITA and an under-reliance on substance use disorder ITA. And so I'm wondering about a breakdown of mental health and substance use disorder ITA as a set of data that would be super interesting to take a look at.
Those are great suggestions, Jim. Thank you. And Jessica, I see you're back. Oh, Jessica just got sent to a breakout. Good. Okay. Jessica's one of our CRIS committee members. She had to step away, but she's going to her breakout now. All right. Thank you, Jim. And Michael, back to your question. I am not writing the report, but my belief is that, yes, there's going to be context added to these charts. I will confirm that, though, so that I'm not just making that up. Elizabeth, and then Roxanne. Elizabeth?
Yeah, thank you. I have a thought following on Michael and Jim's feedback as well. Specifically in looking at some of these outliers, especially the other, I'm really curious about that as well. Will there be demographic data available on where individuals are represented within this? For example, we know that people of color and LGBT individuals tend to encounter the system differently than white communities, typically middle age. And I'm just curious if regionally or just across the state in general, if we are seeing a theme in the proportion of individuals that are ending up in voluntary versus detention versus other? And then within other, what does that look like for minority communities, and how might we need to more adequately make sure that our minority communities are not only encountering the system in the same way, but are encountering peers who feel like them and represent them, and that they feel like they can relate to when they are in crisis?
Elizabeth, thank you for making that point. And I'm looking in particular at theme number 5, person, family, and community-centered approaches to delivery of crisis services. We've heard a lot from CRIS committee members about the importance of providing the right support to the right, at the right time for the individual. And so you raise a really good point about doing a deeper dive into some of these data to understand how they might shake out differently for communities of color or LGBTQA communities compared to white communities. So thank you for raising that, and I'm going to make a note of that as well.
Yeah, thank you. And I apologize, I don't remember who was mentioning like essentially peer services a few minutes ago, but I think the same theme there is going to be really important. I know Representative Orwell and Senator Dingra have talked a lot about the importance of peer work within the crisis system, and just noting proactively that if we are going to work on enhancing our peer-based system, we want to make sure that the peer system is representative of the people that it's serving. People are going to be more likely to respond to peers that feel like they can relate to.
Elizabeth, that point is I've again very heartfelt, I think, amongst many of our CRIS committee members when we were doing our individual meetings with them before the first committee meeting. I heard that a lot, and from community, some of our representatives of communities of color, as well as representatives from rural communities, for example. So thank you so much for raising that. Roxanne, and then I have a comment in the chat that I'll bring up. Roxanne?
I'm Roxanne, and I feel there's discrepancies in with diagnoses and stuff. For example, I have autism and a traumatic brain injury, but sometimes they view that as having schizophrenia, which is not okay. And I've been like in foster care my whole life, and like I am bisexual, but I don't know how to get into that, but I feel like there needs to be more support services out there so people don't end up homeless like I was for like 3 years, because I was running away from a domestic violence situation and wasn't safe. And I hate it when my med provider's like, so how's the schizophrenia going? I'm like, didn't you just like hear what I said? And I'm not saying that's a bad thing or a good thing. I'm just saying that they don't always understand where I'm coming from. And, my brother, who I knew as my grandpa, he committed suicide on July 7th, 1998. And I miss him a lot. And I've actually attempted like 7 times suicide. But like they had to keep changing my meds, and I'm still like, about the system, they're not always giving me the stuff I need. Like I've been waiting for 3 weeks to get my new medication before I go to my surgery in January, because I have a lesion on my pituitary glands, which is causing chronic migraines. And so yeah, and like because I was human trafficked and stuff, there's a lot of stuff I don't know about myself, but there's also like I have all these physical problems because of it. And I feel like there needs to be more support out there so people who have been human trafficked can actually go by their birth name and stuff and not have to deal with the system. Like for me, like Roxanne's hard for me to go by because that's what my abusers like kidnapped me said. And but yeah, so I go by Adia because my birth name's Adia Hala Addison. I'm not going to give you my last name though. But yeah, anyways, so I feel like there needs to be more support in those areas. And I live in an adult family home, which I've lived in for like 3 years now. So, well, not 3, almost 3 years. So I just wanted to bring that up because I feel there's discrepancies between diagnoses and stuff. And I feel that the system doesn't always listen to you. And I think that's all I have. Thank you.
Adia, thank you so much for sharing your personal experience. Actually, that's very apropos after Elizabeth's comment about the importance of having the support. She was referring specifically to peer support, but the support being from people who understand and listen and come from or look like the people they're supporting come from similar backgrounds. So thank you, Adia, for sharing that with us. I do want to mention we have a comment in the chat. There is a significant percentage of people in crisis served by both adult and children mobile crisis services that have private insurance. More needs to be done to have private insurance contribute financially to supporting our crisis services across the state. In addition to increasing state dollars to fund crisis services, we need private insurance to pay their fair share. So thank you for that in the chat. We just have, I think, Brittany, it's another minute together, I think, or 2 minutes. So any other before we are rejoined by our CRIS committee members and hear from them about what they talked about. Any other final words on these themes? What you think might be missing or might need more context or detail? While you're thinking about that last question, I just want to express my appreciation for everyone who contributed today, both verbally and in the chat. You provided some great and rich feedback that I know will really help make the report as it's built out even stronger. So thank you so much for coming to these meetings and for participating in this conversation and sharing your personal and professional experiences with us. This was really valuable. And I hope we have that. So it looks like the breakout rooms are coming back. So I will stop talking now. Okay. Welcome back, everyone. Give the windows just another minute to open up here. Okay. Great. All right, let's start the sharing out and make sure Liz is back with us since I'm going to call on her first.
I'm here.
You're here. All right, Liz.
Here I am. Okay. All right. So Jamie, how long do we have?
So we have about 20, 25 minutes. And so what we're going to do is facilitators from each room are going to share the key themes of what they heard. I'm going to pause between each facilitator and ask CRIS committee members if there's anything important that we missed from that room, recognizing that we are recording and we'll be incorporating all of the discussions into the breakout room, into the meeting summary. So don't worry that we've missed anything, but we do want to make sure everyone gets to hear kind of at a high level what you talked about. And then I'm going to ask each subsequent facilitator to build on what the previous facilitator said. So you can say, we echoed a lot of what was heard in Liz's room, and here's what else we talked about. So we'll do it this way. Let's start with Liz, and then I'm going to go to, so I'll get my facilitators ready so you know when you're going. So start with Liz, and I'm going to go to Betsy, and then Michael, and then Suzanne, and Mark, you get to wrap it up. Okay?
Okay, I will do my best. I had a great group. Everybody participated and was very vocal about what they thought about the themes they heard about. There was a little bit of frustration around some things that were not reflected in the themes. And I'm actually going to share the slide because I know that I'm lucky because I have the slide deck and I was sharing earlier, but this slide here, and I can make our comments really tangible. So in general, there was a sense of missing pieces in this continuum of services that are being conveyed here, and wanting to know like where is the first responders, where are first responders reflected, where is follow-up reflected in our delivery system, where are peers, and so I think that is an overall comment. In addition to that, going on the left-hand side, we don't have much said about other types of payers, commercial payers, and Medicare, and how does that play out in this system, and that we need that information. We need information about those types of systems, those pieces, the delivery system and the payers, in order to really understand what's going on, because there are some serious gaps. I think particularly on the first responder piece, there's a lot of concern that that was not called out more clearly. And people wanted to know more information about what was happening in those systems. How many people are making calls to police and fire, and what's the impact over there? How many people are showing up in emergency rooms? Because those are components that, even if they may not be part of what we consider the long-term crisis system that we're redesigning, the impacts and decisions that we're going to be making and are seen across those other systems. Where does the line with behavioral health end, and where does crisis start? Just that we need to take a step back and look more holistically. So that was the sort of frustration and concern that I heard from folks. And I think the underscoring point was people recognize that this is a convoluted and confusing system, and we kept coming back to what does this mean for the people that are not being served or trying to be served by the system, and that if it's confusing for us, it must be even worse for the people that are using it. So I don't know if anybody in my group has other comments, but
anything that Liz missed there for folks in the group? It sounds like you captured it really well, so thank you for that report out. So Betsy, you're up next. Do you want to echo or add to what you heard from Liz?
I'm going to echo, actually. It's interesting that Liz's group went to the same place our group went to. We talked about 911 is the feeder, and 911 isn't represented here. So we really need to, if we're talking about the current state, speak to 911 services and really understanding that that's a critical partner in the crisis system. I also heard from folks about a missing provider perspective. So not many surveys noted, and that the feeling is that we need to hear more from providers to really understand what's going on in communities, as well as some of the good things that are happening. I think there was a sense, and I'm gonna, Joan, I'm just speaking for you, that maybe this the themes are more kind of deficit-y related than really being able to call out all the wonderful things that are happening. So that was another theme. And then just the methods that we're using to communicate currently are, I think the word used was bureaucratic. And so, maybe not so much just reaching out by email. How do we really reach into communities and offer opportunities for folks to contribute to this process that are non-traditional ways? So a little bit more of what the kids are doing. My group, did I miss any key thing? Oh, and the other thing I want to mention is that we did acknowledge that that it would be helpful in framing this report to speak to what it is doing and what it isn't doing, and that this is really, and I mentioned this in the steering committee last week, that this is a framework and it's a beginning point, and it will not be all inclusive. It won't be, comprehensive for the whole system, and that it would be helpful to frame that in drafting the report so that folks know what to expect, and that it's not disappointing because of all the things it isn't doing. We speak to what it is going to do, but we also say that this is what it's not going to do, and that, again, pointing towards the future work that we need to do, going forward, and that this fits, we are here, and there's much, much, much more to do. So I appreciated those comments.
Okay, so Betsy's group, anything to add to what she said that you felt like needs to be called out?
I'd like to add something real quick. Our group also talked about the statement in the report that talked about the over-reliance on deep end services, and that less is spent on upstream preventative services. And I thought that it would be helpful if the report sort of called out in sort of its introduction or in some fashion that we need a stable outpatient community system that can help people sooner in the course of their illnesses, so we can prevent people from having to call 988 in the first place. Hearing those personal stories this morning about how these crises appear in adolescents and children and youth, if we could help them sooner, I think we'd have a better crisis response system overall if less people need to utilize it.
So not just what's happening after the call, but what's happening before the call. Yeah, great point, Joan. Thank you. Okay, Michael's group.
Yeah, I had a great group who had a lot of things to offer. And so I know I'm not going to capture it all, but some of the main themes is they were impressed by the amount of work that went into kind of pulling lots of stuff together, and that what didn't seem shocking to them, like it seemed to capture a good amount of what folks knew, which is validating in some sense. At the same time, it still was shocking to hear, like there's no kind of comprehensive statewide approach to this aspect, or, things look different in these areas. And so just that lack of consistency across the state just kind of really stood out to folks. People wanted more time to dig deeper, but they thought that, a couple of things that were missing that maybe could be helpful is there was no talk of commercial health plans and what kind of role might they play as either funders or partners in this work in designing a responsive system. Also echoed the thing around not a lot of information around wraparound services or those kind of things that either prevent people from going into crisis and or service stabilizing features when folks are coming out of crisis. And so maybe some more information on that. There was a lack of racial equity kind of analysis throughout that people noted in there, and that while we talked around person and family-centered care or trauma-informed services or culture responsive, maybe a better understanding of some of the racial inequities or equities in there might be helpful. Kind of tied to that, I think folks expressed, or we found this theme that folks were kind of hoping that maybe the report could shed light on how certain populations might experience the crisis system. So people with comorbidities or folks that are like youth or adolescents, or maybe people who are experiencing homelessness, and how our current crisis response systems kind of, how they experience and walk through that system from their perspective. I think a couple other things that, or one thing in particular that someone noted is that number 9 as a theme could be a really good role for CRIS, which is around like, does a CRIS create a vision of what kind of outcomes they want to see for the response system? And could that be something that the CRIS spend some time really thinking about? So those were some of the highlights. I'm sure I missed some if folks from my group want to offer up any others.
Michael's group, any other highlights that you want to make sure we call out? Michael Robertson.
Yes, along with the equity piece is with that equity, we know that there's a correlation with quality of care when it comes to that. On that note, it's automatic, and then it's the evidence is in. So we touched on that too.
Thanks, Michael. Anyone else from Michael Anderson-Nathy's group? Okay, Suzanne's group.
Okay, we had a lot of similar conversations to what others shared, which I won't repeat, but I will maybe just put a little emphasis on some of when you talked about data. There was a conversation that, and Liz talked about not mentioning the whole continuum, but a need to address things like ED measures and other kinds of ancillary support or ancillary emergency services need to be part of the collective data and reporting out. The data also needed to not just be operational, but really look at outcome metrics and like, is there a difference being made in people's lives? You need to know how fast, but also is there a difference being made in people's lives? And to ask people receiving services their experience of
525 of
Thank you, Kathy. To ask those who receive services their experience of care. As it relates to, there was a mention too about on the financing, it talked about we need to also acknowledge that sometimes that pressure to those higher levels and involuntary, one of the issues that's precipitating that is that there's not available funding for all people right now, and that's what contributes. And so that needs to be clarified of what that issue is. There needed to be information also about commercial health plans, and there's actually a report on the Department of Insurance that talks about payers for commercial that folks may want to look at. But the big thing that at the end of our conversation that came out is that in order for us to move forward and solve things, we got to get on the same page and have a shared definition and understanding of the words that we use. If we can't all get on the same page and understand the same words, imagine for those who are receiving services, how difficult it is for them. And then there was many other things that other people said, but I won't repeat those. But I do want to ask the group if there was anything I left out that we did need to bring forward.
Suzanne, may I just ask a point of clarification when you're talking about definitions? Are we sort of circling back like on what we were talking, some of the questions that came up earlier with respect to like what we call a crisis bed or,
right.
Okay.
Just like some basic definitions about service types, but other common words that are being used. So not just like the categories, but we need to have shared language.
So maybe a glossary that we keep updated.
That's exactly what was asked for.
Okay.
Yes, a glossary.
Excellent. Yes, I think that is certainly something we could do. Kashi.
Sorry, the slight expansion I wanted to make on that was that in addition to a glossary of a sort of definition of shared terms, I think we need a shared definition of what we call the crisis system, because what was missing that others have mentioned is that, you know, emergency departments, law enforcement, first responders, follow-up services, community behavioral health, they're not represented here, and they are currently part of the crisis system. And so I think part of that theme was about a shared definition of not only the terms that we use and what they mean to everybody in this room virtually, but also what we all mean when we say the crisis system, and are we talking about the same thing?
So what is that universe we're talking about? Okay, excellent.
Jamie, one other thing that was brought up, that there wasn't information to understand the kids' available services and adults, and are kids using it, not using it, what's available for them or not. And so not only just tracking it, but making sure that's available for kids.
It's really being utilized.
Not just provided, but actually being the uptake on it.
Yeah.
Great. Thanks, Kathy. Thanks, Suzanne. Thanks, Kashi. All right. Any other things to add from Suzanne's group? All right, Mark, you get to be the anchor.
Thank you. We had a very great group. Everybody participated. Lots of great feedback and thoughts. So luckily, a lot of the themes that are mentioned here were echoed. So I'll just repeat quickly some of them that were echoed. One was the shared definition of what is crisis and what do we mean for that for the purposes of this committee and what they're charged with. And then the more supporting question is how we're defining each of those services. The missing the body of the response from the 911s and that whole aspect of supporting that information into the comprehensive assessment was brought up. The recognition that we don't have the ED use in there was brought up. The recognition that we don't have information on commercial insurers in particular was also brought up. There was also just an overall comment that because it is a complex system, it can be very confusing, not only to those helping for all of you on the technical side here, but as committee members and most importantly to the public. We need to find ways to communicate the information in this assessment report in a format that is easily accessible to the general public as well. We can always provide more detailed information that have interest at that level. Some other things that are unique to our group was that there seemed to be a lack of recognizing the crisis continuum from the substance use disorder perspective, and not for them individual, but also the folks with comorbidities between substance use disorder and behavioral health conditions. And then I think one other theme was that variation can be accepted and acknowledged in some areas. And then there could be other areas for more of a statewide standardization, whether it be reporting of outcomes or things like that. But we can't lose sight that there's going to be a balance between some standardization, but also local variation. And then lastly, all the themes should really transcend a focus on meeting people where they are in the delivery of services.
Okay, great summary, Mark. Thank you. Mark's group, anything to add that he might, that you want to make sure we highlight? Okay, well, I got to facilitate a conversation in the main room with our community members who are participating today. And I imagine you will not be surprised to hear that many of the things that you discussed in your breakout rooms were also discussed in the main room. But I do want to add just a couple of key points. Children and youth were brought up here, but there was an emphatic point in the main room and a lot of nodding heads about missing data and services around children and youth, particularly the youngest ones. So that's something that we discussed in our room. Another piece that came up that I found to be particularly important context was in the theme, I think it was number 6, where we talk about collaboration and coordination. One of the members of the public talked about communication and how there's many, many barriers in the current state to communicating across systems. Many forms you have to fill out, many hoops to jump, many things that you can't actually share with different members of the crisis system. There was definitely interest in seeing contextualization of the data, adding more detail like demographics to get at that equity perspective, for example, how different communities are actually experiencing the system, depending on where they're coming from. And also breaking it down by use of the substance use disorder system versus the behavioral health system. So those were some key points that came out in the main room. If you do get a chance, CRIS committee, please watch the video when it's posted. There were some really great comments from our members of the community, but of course we'll also put it in the summary. So just a couple of, I just want to kind of do some quick synthesis, and then Nicola or Liz, if we could share those final slides that talk about next steps so we can remind our CRIS committee members about providing feedback. And Kashi just offered to help with the children and youth part. So thank you, Kashi. We will definitely take you up on that. So I think Kashi may have said it really well, and it summarized a lot about really understanding the whole universe of who we include and getting on the same page about that whole universe of who we include in our crisis response system. That's something that would be really important to articulate in this report and for the CRIS committee to work on. And then addressing some of those pieces that people felt were missing in the current system. So the ancillary emergency services, first responders, for example. Jane Beyer had to jump off, but she offered to help out with the commercial health plans piece that was raised by a couple of groups. And of course, we have to do some work on adding context around racial equity and other demographic breakdowns. And finally, it would be useful to set this up with helping clarify what this comprehensive assessment is and what it isn't, and what's ahead, and how this is going to be used in our work. And with that in mind, let's just talk briefly about next steps. Mark, were you going to present these, or is this coming from Betsy?
I think Betsy has this one.
Okay, Betsy, you want to just walk folks through the next steps on this?
Sure, trying to get off mute. So this, we are here today on November 16th, talking about the themes and the sub-themes. And then we have a couple of weeks where all of you CRIS committee members will have time to provide us written feedback on the themes, and give us as much detail as you can, as possible, so that we can work in this next period on incorporating some of the great suggestions and really drilling into some of the additional context that we need to provide. So comments to Nicola Pinson, you see her email address there. And we appreciate the support from Jane and others to really, and Kashi to really look at some of the information that we need to include. We'll need to go into that 911 as well. I'm sure we'll tap Adam and some others to make sure that we're adequately describing the current 911 system. That's where we are in terms of next steps for the next couple of weeks.
Okay. Can everyone mute their mics if they're not? Thank you so much. Sorry, Betsy.
That's it.
That's it. All right, great.
There's one more slide.
One more slide.
Okay.
Yes, so you'll see this, the milestones here with the dates. I just spoke to 11/16 and 11/30, and then we'll be working on drafting a report for steering committee approval that will be delivered on the 20th. And then we have CRIS member comment period between the 20th and January 13th. We want to give you understanding that it's we're talking about over the holidays, and that's a lot to do, a lot to ask of you. We're offering 3 weeks for CRIS member comment, and those comments will be posted publicly as a companion to the report. And again, in the interest of contextualizing what the assessment report is and isn't, we think it's really important to have all this information incorporated, in a place so that we can use that to do the work in 2022. And on the 27th, the steering committee will ideally approve the report for submission, and then the final report will be delivered on December 30th. So that's where we are at this moment.
Great, thank you, Betsy. So before we move into public comment period, a couple more action items. I'm going to turn it over to Amber, who has an announcement, and then we'll talk about public comment. So Amber?
Yeah, hi, thanks, Jamie. I'll keep this pretty quick. This is really just sort of a preview for the CRIS committee. Some of you will know this and some of you may not, but in the spring of this last year, the governor issued an executive order that would create a blue ribbon commission on the intersection between behavioral health and criminal justice. Part of what that does is it would create a group that is composed of members of the community, members of state agencies, some members of the CRIS committee. I think it's 3 members of the CRIS committee, as well as 3 members from the CIRSA committee, which is the committee that was created out of the Blake legislation that's in regards to substance use recovery services. So I just wanted to flag that I think we've kind of put together a framework of what that group is going to do and how it's going to work. So we're going to move into very soon the process of the governor inviting people to participate on that commission, and there will be an opportunity for CRIS to think about who that might be from the CRIS committee. I'm happy to share the link to the executive order. Jamie, I don't know if I should send that to you in case people want to take a look at it, but I'm happy to share it whatever the way is easiest to do that.
Yeah, Amber, go ahead and send it to me, and we'll make sure it gets out to the group. Thank you for that.
Yep.
Okay, so any questions about the action items, next steps before we move into public comments? Okay. All right, so we have 10 people signed up for comment, and Nicola just did a scan and it looks like we're seeing 4 people present. So I don't want to miss anyone. So I'm still going to read all the names, but I'm going to skip pretty fast over you if we're not seeing you on the participants list. So please raise your hand if I inadvertently skip you, and we'll make sure we get back to you. I'm going to remind everyone how the public comment period works. I'm going to share my screen in just a moment, and it's going to have the timer on it. You have 2 minutes today to make your comment. So please keep an eye on the timer and keep your comments within those 2 minutes. When that timer goes off, I am going to ask you to wrap it up. And again, this is just to make sure we make time for folks to make the comments every time. Let's see, what else do I need to tell you? When you start making a comment, if you could state your name, please, that would be great. And also, if you have a written version of your comment that you can email into that email address I posted earlier, and I'll repost again before the end of the meeting, that really just helps us make sure that we capture your comment fully. So I'll do the usual where I read 3 names. The first name is going to be the first person up, and the next 2 names are going to be the ones I'm going to call subsequently, so that can help you prepare. So Nicola, why don't you take that slide down, and I'm going to go ahead and put up the timer slide on the full screen. All right. So first up is Danette Boyette, followed by Lisa Stridinger, followed by Christina Suarez. And I don't think we saw any of them on the participation list at the end of the meeting. So I'm going to move on. Gina Casillas. Again, if I miss you, just raise your hand and we'll make sure to come back to you. All right, I do see Patty Horn-Bryan, followed by Phyllis Cavins, followed by Roxanne Slayton. So Patty, when you're ready, if you could turn on your video camera and unmute, and I'll start the timer.
Well, I already sent one comment in the chat. Jamie, do you want to read that I already made? I think I sent it to you because it had to go to a particular person, but it was regarding the names we use. And I sometimes hear people here on the committee say people suffering from or having substance abuse disorder and behavioral health disorders, which I understand is kind of an umbrella thing. But a lot of people, including the Treatment Advocacy Center, believes that serious mental illness should be called that and not lumped under behavioral health as if it's a choice, a behavior that people are acting out. So it's a behavior. It needs to be considered a medical, neurological illness, because that's what a lot of us do believe it is. So that was one comment, but just on the language we use. But then another one, somebody was saying today that different hospitals give, I think they were inferring give the same care, can treat anybody or something like that. But in our NAMI parent, or not parent, but family support group meetings, we noticed that those of our adult children or family members who are on Medicaid get to go to certain hospitals, and they get a much shorter span of time if they're on an involuntary hold. And those that have really nice insurance like Primera or Medicare plus something else, they get to go to, what's that hospital? Swedish Cherry Hill, Swedish up north someplace in Alderwood or something, and they generally stay 5 or 6 weeks. They just get a lot more time in, and it does appear as though people with, quote, really good insurance and not just Medicaid get more service. So just thought I'd make that comment.
Thank you, Patty. And I put the written comment that you provided in the chat. I sent it out to everyone so they can see that. So thank you for making that point. All right, I checked to see who else is on the screen. So it looks like next up would be Phyllis Cavins, followed by Roxanne Slayton, followed by Daniel Montana. And am I right, Nicola, that Phyllis is not on anymore?
I'm on.
Oh, good, wonderful. Oh, okay. Go right ahead.
Hello, I'm Dr. Phyllis Cavins, and I'm a pediatrician and the medical director of Child and Adolescent Clinic in Longview and Vancouver, Washington, here in Southwest Washington. I would like to repeat many of the comments that occurred in our breakout session, but just to emphasize it, that as you redesign the delivery system for crisis care, I'd like you to ask the question, how well does this redesigned system serve the youth with their initial crisis? And unless we handle that initial crisis well, we will just continue to see this child in crisis. So I feel that if we, in our redesigned system, focus on collaboration as what I see as the biggest gap in our crisis system, if we focus on collaboration and include primary care for youth as a collaborative partner, we could best get at the crisis and address the issue of suicide prevention. In the care of children and youth in our state, the 0 to 18 population, 95% of them have insurance, either public or private, and 85% of them have seen their physician in the last 12 months. So that's our opportunity to first serve the child as a whole child, all their needs, in a family-centered approach that's community-based, that has developed or has an ongoing relationship with the behavioral health providers in our community. And many of the primary care pediatric clinics now are moving towards integration of behavioral health.
Dr. Cavins, excuse me, I apologize for interrupting, but we're at the 2 minutes.
Thank you.
Yes.
That's my 2 points.
Okay, would you please email the, I'll put it in the chat. Would you please email your written comments? We'd love to have them if you don't mind.
Thank you so much.
Yeah, thank you. Okay, up next, we have Roxanne Slayton, followed by Susan Baird Joshi, followed by Jacob Towell. Roxanne, go ahead when you're ready.
I'm Roxanne. I go by Adia. I've dealt with domestic violence in foster care my whole life, and I have autism, a traumatic brain injury from all the abuse that I've suffered. And I feel that the doctors don't always listen to me. For example, they'll say, well, how's your schizophrenia going? Or do you hear voices? I'm like, no, I never did. The only time that ever happened was when my brother committed suicide. And I used to see him sometimes when I was stressed out, but I'm also Native American. So I believe in like visions, and I believe like my ancestors come back and talk to me. And I'm also Jewish. So a lot of people say, oh, you can't be Jewish and be a Christian at the same time. That's not true. I mean, it depends on who you are. And I feel like the system, like, has you jump through all these hoops, even though it wasn't your fault that the abuse happened to you, but they have you jump through all these hoops and stuff. And it can be frightening because like I sleepwalk and I have seizures too. And I'm still waiting for them to get me one of my medications that I've been waiting for 4 or 5 weeks now. And then when I try to get a hold of people, they don't call me back. And that's a real bummer because like I'd like to get better, you know. And I do a lot of meditation, artwork and stuff. And I actually have attempted suicide seven times. But after every attempt was after a sexual assault. And because I didn't feel like I was worthy enough or valuable enough to keep living, but my attitude and stuff's changing. And so I hope I can help others that have gone through similar situations. Thank you for my share.
Thank you, Adia, for sharing with us. Next up, we have Susan Baird Joshi, followed by Jacob Towell. Susan, when you're ready. Oh, go ahead.
No, thank you. My name is Susan Baird Joshi. I'm the Federal Legislative Chair for Washington State PTA. In preschool through grades K through 12 schools, teachers, coaches, and staff are often the first observers of changes in student behavior that could indicate children and youth are experiencing mental health challenges or are in crisis. Children and youth may not feel safe in sharing mental health challenges at home. In fact, homes may be the source of their crises. Adults at school may be the only trusted adults in a child's life. There are more than 1 million students in grades K through 12 in Washington State for the 2020-2021 school year. In King County alone, there are 85,000 students in just 2 school districts, Seattle and Lake Washington. That's close to 10% of statewide student enrollment. I encourage the CRIS committee to include testimony from practicing teachers, nurses, counselors, coaches, after-school activity providers, and parents on your committee to provide insight in how crises can be addressed at school and explore how school adults can help children in crises seek services. Washington State PTA members adopted student mental health as its top legislative issue on its 2020-2022 legislative platform. Moreover, National PTA calls for policies and legislation to support every student's mental health and provide and connect students with necessary behavioral and mental health resources at school and in their community. I will be submitting these comments and can provide additional references. Thank you very much for your time.
You're muted,
Amy, I
Jamie.
think you're on mute.
Sorry about that. I thought I had unclicked it, but it didn't work. Apologize. So next up is Jacob Towell, and then Jake Gillenders. I was just responding to your text. I will have time to take your comment as well, so I'll call you right after Jacob. So Jacob, when you're ready, I'll start the timer.
Great. Can you guys hear me okay?
We can, yes, thank you.
Great. Good afternoon. Thanks for letting me chat for a couple minutes here. Again, my name is Jacob Toll. I'm the chair of the Washington State statewide business resource group Safe Place Committee. We're an LGBTQ statewide committee for employees of the state of Washington. The reason I want to make a comment, it was following the committee comments, and I appreciate all the work that you folks are doing. It's incredible and very needed. Something that the Safe Place program that was initiated by the governor's 1611 directive in 2016. Safe Place is a program for LGBTQ plus community members who are experiencing bullying, violence, or just simply harassment, where they can go to a safe place and get help, get away from those that are harassing them or bullying them, and receive resources. With the pandemic, it's been really tough. We've done some data collection and tracking. So we'd like the committee to consider aligning the CRIS committee with the Safe Place committee with the BRG, just because a lot of our LGBTQ plus members and community experience crises and suicide ideation. A lot of our youth as well out there living on the streets just because they just cannot survive in the homes that they're in. Thank you very much.
Thank you. All right, and last is Jake, and forgive me for if I mispronounce your name, Gillenders.
It's all right. I accept a lot of versions of it. Well, first of all, thank you very much, Jamie, for fitting me in and for the opportunity to get to speak. And I also want to start by commending this group and thanking this group for all of your hard work in pushing our system forward. There's no doubt that it's needed. My name is, I'm Captain Jake Gillenders. I'm the medical officer for the Paulsville Fire Department. And part of my role there is I oversee our CARES program. And I just wanted to jump in and just express a little disappointment in the lack of representation for fire and EMS in this committee. It sounds like that's being recognized in the subgroups, and I appreciate that. And it sounds like we're going to get a little bit more emphasis or focus moving forward. But I just want to make sure that we remain a part of the conversation. Our crews are out assisting these folks every single day right now. And I think there is a wealth of knowledge, a wealth of experience, and a wealth of ability there that it would be an oversight to not bring that into the conversation, see how our services are delivered today, and also see where we fit in the program and the systems moving forward. I think we're always going to have a role in the behavioral health world as EMS providers and field medical providers, and I think it's important that we're a part of the conversation. So again, I appreciate all the work this committee is doing. I appreciate all of your efforts and your willingness to contribute time to this. And I just ask that we maybe expand the focus a little bit to include EMS. Thank you for your time.
Thank you, Jake Gillenders. And to everyone who made public comment today, I put the email address in the chat one more time. So if you can, please send your written comments to that address. CRIS committee members, a correction to something I said earlier, you can submit your comments on the themes, any follow-up comments, things that come to you tomorrow or in the middle of the night while you're lying in bed, or whenever, to Nicola's address. And Nicola, if you could just throw that email in the chat one more time so everybody has that. We'll be collecting that. We'll be sending a follow-up to remind you of the deadlines and dates. You should get that by email. I know 3 hours is a long meeting, and we had some intense discussion today and a lot of information to absorb. And I really appreciate everyone's attention, engagement, and rich comments. I also want to thank our community members who took time out of their day to spend it with us and provide their feedback. So thank you so much. And most especially, I want to thank Jim and Kathy for sharing your stories with us today. Again, it is so important to share those stories and to ground us in our work, and we appreciate it. Betsy, do you want to say any final words before we say goodbye?
Just as always, I want to thank everyone for participation and for offering comments and sometimes, helping us to see where we're missing some pieces. That's what this process is all about. So I just really appreciate you all, and lots of work ahead that we will dig into. Thank you.
And we will be communicating with you by email and seeing many of you in subcommittees. But for those of you that we don't see before next CRIS committee meeting, wishing you a very happy holiday season, whatever it is that you celebrate, and a very happy US New Year. I know it's not the New Year for everyone, but I wish you all the best, good health, and maybe a little bit less sogginess. So be well, everyone, and we'll see you after the New Year if we didn't see you before then. And thank you again. Bye, all.
Thank you.